Once we have identified the pain generator or the offending pathology, and we have decided that we want to go for the transforaminal surgery, the first important step is the entry point selection. And if the entry point selection is correct and we are bang on the target, half of the battle is won. Because once we are inside the foramen, we have very little space to play around. So here we will try to understand what are the possible entry points available in the literature, how are these entry points marked on the patient's skin, what are the indications of each of these entry points, and we will also try to figure out if we can have one standard entry point for one of the commonest lower lumbar herniations and lateral stenosis. So this is the yes technique of schematic diagram already described by Palani sir. This was first described by Dr. Anthony Young. Now let's see how do we mark these entry points on the patient's skin. This will be a revision for you as you have already seen it once. So suppose we are standing, patient is in prone position and we are surgeon as standing on the left side of the patient. So this is the first step of the marking of the entry point. This is the X-ray or the C-arm is in AP view and we are marking the vertical midline. So this will be a straight vertical midline. This will be the first line marked. Now the next will be the horizontal line which is marked at the level of the disc or the pathology, and this is again on the AP view. So this is the second line marked horizontally at the level of pathology. Now the next, all the markings will be in the lateral view. So the first entry point is the posterolateral entry, and this posterolateral entry is marked by measuring the distance between the dorsal surface of the patient back and the anterior vertebral border. So in the C-arm image, our rod should reach the anterior vertebral border, and if we see on the patient back, the rod is placed such that this distance from the midline to this rod is the distance we have to mark, and this will be the posterolateral entry. So this will be a bit difficult to explain here. If you will practice it tomorrow on the patients in the cadaver, you will be more clear in that. So just remember the posterolateral entry is marked anterior vertebral border, and here it is the distance is marked in the patient's back. That is the dorsal aspect of the patient's back. Similarly, the second entry point is the 45-45 entry. So here is also the same, the method is same, the C-arm is in lateral position. Here the rod is reaching at the midpoint of the vertebral border, and this distance of the rod is marked on the patient's back. So this is the second entry point, which is the 45-45 entry point. The third is the DFJ or the dorsal of facet joint entry point. So here we have to place the rod on the facet joint dorsal aspect, and that point we have to mark on the patient's back. So this is pretty simple. The DFJ entry point marked on the dorsum of the facet joint. And the last is the tip of spinous process entry. Again, the rod is placed on the tip of spinous process as we can see here, and this point is marked here on the patient's back. So these four entry points you can remember. These are the conventional entry points which are available in the literature. 45-45, posterolateral, tip of spinous process, and the DFJ. So these are the four entry points from the medial to the lateral of the patient's dorsum. Now if we see the upper lumbar levels, the most common entry point or the most lateral entry what we can use is the posterolateral. That is, we can either use the 45-45 or the posterolateral, because we want to avoid entering into the peritoneum. So for the upper lumbar levels, just remember we can use either the 45-45 or the posterolateral. So this is a image you can see. This is how we are marking the posterolateral entry. Now we come to the lower lumbar levels. Here we can have a varying wide range of entry points ranging from the posterolateral. This is the posterolateral entry. TOSP entry. This is the dorsum of facet joint entry. So you can see the trajectory is changing. The significance of it we will discuss later on. But these are the three entries we can use for the lower lumbar levels. And if we consider the lower lumbar levels, which are the common pathologies, the safest entry point corridor is the posterolateral through the TOSP entry. So this is the common corridor in which we usually work from PL to TOSP. You can see here the another entry point is the PL TOSP. That is the midpoint of PL and TOSP entry. So this we have to remember. So these are the 4 entry points, and this is the safe corridor in which we usually work. The PL to TOSP corridor. Now we know the 4 entry points, but are these entry points same for all the patients? So let's see, these 2 patients are there. One of weight 90 kgs, height 162 centimeter, another of 65 kgs and 175 centimeters. So the next question comes, can we have the same entry point for both of them? So the answer is no, because all these entry points are changing with the physical parameters like weight, height, BMI of the patient. So now we try to understand, can we have some entry point which we can use for all the patients? So if suppose we consider an example of a patient of 40 kg, 70 kg and 100 kgs, how the PL entry point is changing. Let's see. So suppose in a 40 kg the PL entry point is 9 centimeters, but if the weight of the patient increases to 70 kgs, the entry point changes to 10.3. And if the weight of the patient again increases to 100, the entry point increases to 11.7. So we can't have a same distance or 1 point entry for all the patients. Also the trajectory observed is also changing, that the angle of the entry is also changing with the physical parameters. So likewise we have seen the example of PL entry. Other entries are also similarly changing like this. The TOSP, DFJ and the 45-45. All these are changing with the physical parameters. So this is an example. You can see the entry point in 45 kg and 125 kg. All these are changing. Also PL TOSP, that is also changing. Also we have seen the trajectory is changing. In the 45-45, suppose in a patient of 45 kg the trajectory is 40, so it is changing to 49 in 125 kg patient. But here we could find a very interesting fact, that this entry PL TOSP in a 45 kg it is 27 and in a 125 kg it is 26. That this PL TOSP trajectory is not changing much with the physical parameters of the patient. So this was an interesting fact that we could find out, and we could use it in a future, that we'll see. So this is how the trajectories are changing with the weight of the patient. You can see 45-45, 80 kg and 120 kg, the trajectories are different. This we have already discussed. Now also for different pathologies like the central herniations, paracentral herniations, foraminal herniations or the lateral distal stenosis, we can't have one entry point, because PL and TOSP, which are the safest corridor entry points, they have some pros and cons that we will discuss. So that we will discuss in the next slide. Now if we consider the PL entry, so it is away from the peritoneum, but from the PL entry the entry is more vertical, so there are less chances of compressing the exiting nerve root. But the issue with the PL entry is that it is sometimes it is difficult to reach the central part of the herniation, and we have to do more foraminotomy or the annulotomy is required to reach the central part of the herniation. The disadvantage with the TOSP entry is because it is more shallower and horizontal, there are more chances of exiting nerve root injury and dysesthesias post-operatively. So once we have tried the PL and TOSP entry, PL-TOSP entry, which is the midpoint of PL-TOSP, both these disadvantages of PL and TOSP were taken care of. That there is less chances of exiting nerve root injury also, and there are more we can reach the central and paracentral herniations better without doing much foraminotomy or annulotomy. But the only issue was we have to mark both PL and TOSP. Then only we will know the midpoint of it. So we tried to find out, initially we were marking all these entry points and then we are marking the PL2SP. But over the time we had tried to figure out whether pre-operatively we can find the formula so that we can find the PL-TOSP entry based on the patient physical parameters. And this was done after doing statistical analysis of more than 300 patients. And what we found out that the PL-TOSP entry that was changing proportionately with the physical parameters. So if we have the weight of the patient and the abdominal girth of the patient, so pre-operatively we can determine the PL-TOSP entry for that patient. So this was the formula determined, that was y is equal to 6.88 plus 0.06 into weight plus 0.024 into abdominal girth in the centimeter, and where y is the PL-TOSP midpoint of PL and TOSP. The only exception was it was not applicable for BMI less than 18.55 that are very thin patients. So this was the prediction formula that was determined, and then it was validated as well. So till now we have experience of more than 800 cases. Last 3 motion segments with either central paracentral herniations or lateral dysstenosis. These are the main indications for this entry. It is not like all the pathologies can be dealt with single entry point, but for the most common pathologies that we encounter in the lower lumbar region, we can deal with these entry point. And the accuracy of this formula was more than 95%. That was the difference with the actual entry and the formula was less than 1 centimeter in more than 95% of the patients. And also we can do the work that we want to do, that was the significant improvement in functional outcome. There was very few complications of dysesthesia inadequate, and there was no incidence of post-op any deficit or dural tear. So this then we analyzed and published. That was published in the Asian Spine Journal. So the take home message what I want to give is the physical parameters play a significant role in the selection of entry point. Therefore, for the first few cases we should know all the entry points, how to mark these, and also the pros and cons of all the entry points. For the higher lumbar pathologies, 45-45 and posterolateral entries are more important. For the lower lumbar pathologies, common pathologies, PL-TOSP is better. None of the entry point can be static, like Palani sir already described. You can't just say it is 10 centimeter from the midline, it is 4 hand breadth from the midline. That is just an idea. We can't precisely say the entry point unless we mark these on the patients. PL-TOSP entry point that we recommend for lower lumbar pathologies, for central paracentral herniations and lateral stenosis. This we have studied over more than 300 patients, determined it and validated as well. So that we are now using routinely, directly marking the PL-TOSP and starting the surgery. This also reduces the time of the surgery and the radiation hazards which we have to encounter for marking all the entry points. And this can be determined by a formula that we have already discussed. The only exception is BMI less than 18.5 should not be considered. Also, there is an angle guide which is in process of validation, and approval is awaited for entering the PLTOSP. Once we know what is the PLTOSP entry, we can precisely know what is the precise angle through which we can directly reach the pathology. So initially for the first cases we should know all these entry points, but once we know the pathology and the pathology is under this central paracentral herniations, we can straight away use PLTOSP entry point and directly approach the pathology. Thank you.